Okay, so we're working through our way through Edinger, and we are up to our differential diagnosis for chief clinical presentations, which is a really nice thing to talk about because it's so clinical. It's the way that the patients present to you in the consult room with the owners, kind of weird histories and things like that. So today we're talking about coughing, nasal discharge, and I'm going to run through some coughing stuff, and Josh is going to do nasal presentations. Do you want to start, Josh, or do you want me to start?
Yeah, sure. Happy to start.
Go for
it. Yeah, I don't know if everyone else read the chapters, but I found the sneezing and nasal discharge one was really good, but the Epistaxis chapter I thought was like just dipping into so many different chapters. Like it was probably going beyond what we probably needed to. So I'm probably going to focus more on just like the sneezing, nasal discharge chapter because there's so much the same stuff, really. Yeah, so I thought it was really good as that the first kind of part of the chapter talks about how like what sneezing is. Like we all know what sneezing is, but it's nice when they kind of put it down as like what the definition is, because it really, I think, just helps you try and figure out the differentials from there. But they defined it as an involuntary protective reflex that expels air from the lungs through the nose and mouth in a sudden explosive manner to try and clear the upper airways, which I think is important because I feel like I've had cases before which I thought were more lower airways, but I think it was sneezing and vice versa, really. But it's a protective mechanism mostly. So, and what can trigger that can be really anything that's an irritant or that's either physical or chemical. And again, I think that's useful to know, just trying to figure out what can trigger these. So with that said, I think the chapter kind of broke it down in a really good way, had a really good table there talking about all the different differentials, kind of breaking it down into, I guess, things happening that are systemic or extranasal, or nasal, or have something happening in the nose or the paranasal sinuses. And again, I think it helps kind of break down when we're thinking about our differentials. It's very important and I think it's very easy to forget that there are systemic causes and just focus on where the problem is. So I thought it'd be good, like collaborative exercise, to try and go through the differentials and try and kind of hit the big categories. If anyone wanted to have a go. And Anna, please jump in anytime. I love that this is more of a discussion. So.
The only thing I want to add to the very beginning of this discussion is that I've had so many clients referred or coming in and saying, my dog's sneezing, my dog's coughing, my dog's having fits, and they're describing something completely different. So I think it's really nice to have that definition in my head and make sure that what I define as sneezing is what the owner defines as sneezing or coughing or fits, because like reverse sneezing has been described to me as fits on so many occasions. Or coughing, which is obviously localizing. If you're going down the coughing pathway and it's reverse sneezing, you're going to end up in the wrong body cavity.
Yeah.
The definitions are really nice to have in your head, so I like that summary. All right, differentials.
Yeah, differentials. What I think of some, I guess, nasal and paranasal causes, I guess, as broad categories. So like let's, I guess, start with infectious, I guess. Some
viral, I guess bacterial, if that's probably a foreign body, or secondary to something else.
Yeah, awesome. And when we think viral, what are the main ones we're thinking of?
Probably parainfluenza virus, herpes virus, I think, can cause sneezing, in mycoplasma in cats, chlamydia in cats. Is that nasal?
Sorry, actually, I don't know about chlamydia. But the other ones for sure. Like
Fungal as well in dog.
yeah,
Like
awesome.
tuberculosis, yeah.
Great.
And crypto in cats.
Yeah, crypto in
Mhm.
cats.
Would we put post intranasal vaccine in dogs in the infectious category or in the reactive category?
Mhm.
Bit of both, maybe. I feel like there's crossover in some of these, like foreign bodies. Like I find, like that. I think that was under the inflammatory category, but I was like, oh, it's kind of its own thing, really, isn't it? But
Yeah.
I guess how it.
Physical irritant. Yeah.
Cool. Yeah, and I guess so that's good. That's infectious. Foreign bodies. And then when we're looking at inflammatory, I guess what are the big ones when we think inflammatory?
Rhinitis, sinusitis, like lymphocytic, plasmacytic, and all of those categories.
Yeah, definitely. So like LP rhinitis and like allergic rhinitis, they're kind of the ones I think of. Do you think of any more, Anna, when it comes? I kind of just lump them as that. But
no, I think that's it. You're exactly right. And I guess then.
I guess there's even overlap there, really. But
yeah, what category would you put like a stenosis or something under?
Either I guess chronic inflammatory or congenital. I've got it under as like an overlap of both, but I've always thought of it as like just chronic inflammatory kind of.
It's usually acquired, yeah. It's rarely congenital, but yeah, I think it has to be inflammatory. But then it kind of causes. It wasn't the start of it, but then it causes the ongoing inflammation. Does everyone know what we mean by stenosis? Nasopharyngeal stenosis.
Yeah, there is difficulty of the passage of air, or when they sneeze as well, there's difficulty, and then they can be almost a snake, especially cats when they have chronic, I don't know, infectious, allergic, inflammatory diseases. They develop this weird breathing because they have so much dried up discharge in their noses and upper airways. Is that right?
So stenosis just describes a narrowing. So you're exactly right. So anything that narrows the airways and causes increased obstruction to respiratory airflow. Do you want to describe the kind of pathologic sort of like how we would define nasopharyngeal stenosis, Josh?
Right. Yeah. Look, the way I think of it is you've got some inflammation that's circumferential usually, or is the way I think of it. So you've got the circumferential inflammation, and when you have inflammation, there's always going to be healing, which then turns into kind of fibrosis and scar tissue. And then over time, it will just continue to do so and develop this kind of fibrous narrowing, creating a very small hole or small stenosis, kind of like a stricture. Is that right? Or?
Yeah, exactly. So it's like an esophageal stenosis, like a esophageal stricture after an esophagitis, but it's in the nasopharynx. So it's in the kind of circular structure in the back of the nose. So they get a rhinitis, they get a circular inflammation, which then scars down and narrows down, and sometimes even creates a full membrane, particularly in cats. Yeah, it's really interesting.
We saw one recently that was really cool. It was a nasopharyngeal stenosis that lives balloon dilated, and it went quite well.
Yeah.
Dogs and cats?
Yeah, dogs and cats. And weirdly, cats respond better to balloon dilation than dogs.
Yeah, right.
Right.
What's normally secondary to, did you say?
Rhinitis. So if even dogs that, like in particular dogs that have like reflux or vomiting and it goes up the back of their soft palate and they get rhinitis from that. So put that on the differential list as well. Or foreign body stuff up there, or like particularly snufflers, cats with chronic rhinotracheitis.
Right. So the stenosis is in the nasopharynx. It's not like in the in the nostrils or the sinuses. No.
Yeah, no,
exactly. I've got a picture for you. Right. I can bring a picture this time if you want.
Yay! Show us.
Yeah, of a good stricture. But
let me just change the I might have to just change it so that everyone can share. Okay.
Oh, sorry, I didn't bring a picture today.
Oh, okay.
But next time I'll bring a picture. I did bring a couple of pictures, but yeah, look, the stenosis I didn't bring, but I'll dig it up and bring it next time. It's because it's kind of cool, and it also for you, Natalia, just like to see what it looks like just that view of the back of the nose if you haven't seen it. It's always kind of good to know and have in your mind.
And I guess the diagnosed study will have to be with a rhinoscopy, direct visualization, or
We see them on
I think
CT.
CT as well, right? Yeah.
Yeah, if you've got
CT.
thin enough slices, because these membranes can be like 1 millimeter thin.
Mm.
Thin, well, you know. So if your slices are 1.25 millimeters, you could miss it.
Yeah.
And that's
And
a thing.
Normally secondary to acute or chronic inflammation or any.
Chronic. It's usually chronic. Yeah.
I don't know how common it is. I think it's pretty rare.
Yeah.
Um,
Fun, but rare.
I think we were hunting a lot of literature and there wasn't much. So,
What about nasopharyngeal polyps in cats? Like, would that be a cause?
yeah, that's awesome. Yeah. Yeah. So, again, I think I put that under inflammatory.
Mm.
Absolutely. Probably the other big one when we look at inflammatory causes. So, yeah. Awesome. Good as go. So, okay, and then we kind of touched, like, kind of lent into congenital. I don't think there's too much that we think of, but I guess like cleft palate, and it's funny in the book it says it does have stenosis as congenital, but I thought that was a bit odd as well. Anyway, I don't know what they mean by that, but
Like brackies. Maybe.
Sorry?
Brachycephalic dogs?
oh, maybe, yeah, maybe actually that might be what they mean. Yeah, they get those kind of just compressed turbinates that don't.
Yeah.
What about other local nasal diseases? And one I'm thinking of kind of stems from inflammatory. Probably a big one that's seen in GP, I think.
Like a chronic sinusitis in a cat, or sinusitis in a cat, chronic snuffler.
Yeah, okay, that probably viral stuff, I would say, like
in cats, like cat flu, but yeah, kennel cough is more infectious. Tracheobronchitis, like kind of like mid-lower airway, but in the nasal cavity.
What about things outside? Like, I guess it's not. They kind of communicate with the nose, but they're kind of just outside the nose.
Like sinuses?
Honestly, I'm thinking like dental disease. So
Dental disease, like oronasal fistula, or like tooth pertussis.
Yeah. So they're a big one as well. Like, I feel like we get a few referrals for nasal disease, and we do a CT, and it's got a tooth root abscess. And,
Right.
So another one to be thinking of too.
What about nasal parasites? Is that a thing in Australia? Like, have you ever seen them? Or
I've never seen it, but I always think it's on the list. But have you guys seen it?
Never seen it, but I heard of a case in Canberra.
Experienced vets?
oh, Canberra. Oh, really? Oh.
Oh.
I think I've cases in kidney, but I've never seen it myself.
No, me neither. I think because we use the tick treatments.
Oh yeah, that was
So yeah, so I think we just don't see it.
But maybe we'll start seeing more because we're seeing more worms.
Yes.
Last week. Cool. And on my list, I've just got two other categories. One really big category that can cause sneezing and nasal discharge and often bleeding.
neoplasia or
Cancer, neoplasia. What are the common cancers we see in the nose?
Nasal adenocarcinoma.
Lymphoma in cats.
Yeah.
Nasal lymphoma, yeah.
And you can get squamous cell carcinoma probably penetrating into the nose.
Yeah.
And then I think this is the other kind of broader category, which is like sarcomas. Like, you can get like osteosarcomas, chondrosarcomas, fibrosarcomas. But yeah, that's pretty much all the common one. Do you agree, Anna? Are you thinking of any others?
I do. I'm really enjoying the captions. The medical terms, the captions. I love the medical terms. Not really getting it. Sorry. Sarcoma was like interesting.
Probably because I mumble as well. I'm a chronic mumbler. And the last category I got is trauma. So yeah, congenital causes, inflammatory causes, foreign bodies, infectious, neoplastic trauma, and I've got dental disease as a separate category just because I always forget about it. But that's kind of the kind of nasal causes. What about systemic causes or extranasal causes that would cause potentially sneezing, nasal discharge, or epistaxis?
Epistaxis could be a coagulopathy or hypertension. I don't know how much it
Right.
can.
Yeah, I reckon they're the two biggest ones.
Mm.
Easily.
Mm.
So like anything, and like that's where I felt like the epistaxis chapter just kind of went really deep on coagulopathies, and I felt like it didn't have to. Like it just needed to tell us.
There's a chapter about that.
Yeah, the whole chapter on that kind of thing. So, but yeah, absolutely coagulopathies. So rodenticide, toxicity, any kind of hemophilias if they're young, those kind of things.
Would you, for a coagulopathy, would you have that as a sole sign, or would there be other supporting evidence for a coagulopathy?
Sorry, let me say that. And Anna's got something to say. Some wisdom to impart.
Sorry, I can't stop. Pooja just asked, would it be the sole sign of a coagulopathy or not?
Oh, okay.
Epistaxis or bleeding from the nose or like mucous membranes, would you see that typically with a disorder of primary hemostasis or secondary hemostasis? Primary, good. What is primary hemostasis? What are the components of primary hemostasis?
Platelets, one globulin factor.
And one more. That was an excellent answer. Sorry. The other one's very small.
Oh, there's another one.
What's the first thing that gets damaged that the primary hemostasis occurs on?
The endothelial lining, like you have to have tissue trauma.
It's endothelial cell dysfunction. So the vasculitis or like abnormalities of the vessel wall is part of primary hemostasis. So if we've got abnormalities of the vessel wall, platelets, or von Willebrand's factor, we're going to get disorders of primary hemostasis, in which case we often get epistaxis as the only clinical sign, or bleeding from the gums, or like localized like petechiation on areas that are kind of traumatized or have like a lot of airflow, or like if a dog sneezes when it's got no platelets, it's going to cause a nosebleed. So that could definitely be the only sign. It would be very weird to have as the only sign of a rodenticide toxicity or secondary coagulopathy.
Okay, thanks. Makes sense.
Sorry, it's my interest area. I jumped in there.
Yeah, and like when I look at this, I'm thinking more, all right, well, if I've got a nosebleed in front of me, what's on my list, even though like I guess some are more likely than others, but yeah, so I guess any coagulopathy is possible, but it's as Anna said, there's going to be more likely to be other ones.
Would you if you see a nosebleed and the patient has hypertension, would you categorize that as primary hypertension or secondary? Like I think the book was mentioning if a dog gets on some medications that can lead to hypertension, or primary from disease process.
I guess it's you do a hypertension investigation and try and find out if it's primary or secondary. But I don't think you'd be able to tell that early on. But if it's in the history that they've
in the history.
Cool. Okay. And any other ones that can cause systemic causes that could cause bleeding or sneezing, discharge? One other one that I think of with bleeding in particular, but so the other kind of category I think of is like hyperviscosity syndromes. So probably a big one being multiple myeloma, just because there's so many globulins floating around. It just kind of makes the blood very viscous and they can bust vessels, I guess. I don't know if that's the right term. Anyway. But also things like leukemias as well, and anything I guess that could potentially produce more globulins or blood.
But wouldn't that all be under neoplasm? Like it's neoplasm.
I guess more systemic neoplasms. I'm thinking.
Yeah. Not locally.
No,
Yeah, makes
totally,
sense.
yeah.
Mhm.
What about polycythemia vera? Like, would that ever cause sneezing?
Mhm.
Yeah. All right, and then the last ones I've got on here are infectious, but again, I feel like I'm not seeing these before. Like they mentioned distemper and Ehrlichia, but I know there were a couple of Ehrlichia cases recently, but they can potentially cause nose bleeding. I wasn't sure if the Ehrlichia was more because there's thrombocytopathy and platelet issues, but anyway.
And because it's quite a chronic infection as well, they often have hypoglobulinemia too. So they could have a bit of hyperviscosity as well as thrombopathy.
Okay. And then the last one I got was anything that can cause a vasculitis, I guess. Probably the big one that jumped out was maybe an SLE, but again, I wasn't really sure. I was going to ask about that one.
Sorry, SLE stands for
Systemic lupus
erythematosus. Okay, thanks.
We sometimes see drug reactions as well, like causing a vasculitis or like systemic inflammatory responses, just to put on the list. But it would be weird, like you'd have skin manifestations and stuff like that as well, typically.
So that's the list I got from the book, generally. So, but I think the most important, like to summarize that, like looking at trying to break it down into nasal or extranasal is probably the first step, and then narrow down from there. But which is what we'll talk about next. So they had a really kind of good diagnostic approach there, and I think there's a lot to kind of glean from the signalment and the history. There's so many clues, and especially anyone doing exams, like there's always going to be clues in the question. We'll go to that in a second, sorry. But the other thing as well is that there are some other clues that can kind of help localize even in the nose where things are. So we're talking about like sturders and reverse sneezes and stuff like that. They can potentially be in different parts of the nose, whether it's unilateral or bilateral. So as well, like reverse sneezing is more kind of back of the nose, I think of. Is that kind of where like the back of the nose or epiglottis, pharynx, that kind of area. Unilateral or bilateral, like what do we think? What are we thinking when we see something with unilateral versus bilateral?
For bilateral, you have to have the nasal septum destroyed in some way or lysis. So then something more invasive. There is unilateral, like you would have, depending on the history, more like foreign bodies or something in there, like that sort of a thing.
Yeah, for sure. Yeah, so like foreign bodies, especially if it's acute, so that's another thing. If there's an acute presentation, then the foreign body would be higher on the list. There could also be things like oronasal fistulas or dental disease. That's on one side only. Cancers, as you said, but really bad ones might be bilateral. But with bilateral ones, I think of more diffuse nasal disease, so things like allergies or LP rhinitis. Really bad aspergillosis, but they can also be unilateral too. Anyway, just clues that might shift our differential list. What about in young animals? We had like a really young dog come in that was had acute onset sneezing and nasal discharge in the right nostril.
Got a gum nut in
there. A gum nut.
That was my favorite CT finding ever.
What was it?
A gum nut in a dog's nose.
Oh, no.
That's so cool.
So
a
cute.
bean, a black bean. Do you remember the black bean when we did
that was right.
That's crazy.
Right.
Oh dear.
That was good.
Yeah.
For youth.
Yeah, the soft shell crab in the back of the nose.
Yes, I remember that one too.
Oh
it was
God,
the Labrador.
Right. Of course it was a Labrador. How did this
get
Such
a crap.
Not what you expect to see. Anyway, some weird ones there. Yeah, so foreign bodies, definitely. And of course, young animals, you start thinking infectious as well, especially if it's acute onset in a cat, and viral is a big one, or older cats as well. What about if you have an old animal come in with a nosebleed or nasal discharge?
Neoplasia has to be higher on the list.
Yeah, I don't know. I feel like that's my experience as well.
I think a really good question to ask is, do they sleep in your bedroom, and have you noticed any change in their breathing sounds while they're resting? Because when their mouth is closed and when they're breathing through their nose, they'll go, oh yeah, they got heaps louder, or no, they're completely fine. And that helps me go space occupying or not space occupying as well.
All right, and what about long-nosed dogs that come in with nasal discharge and sneezing, maybe bleeding?
Aspergillosis, you should have on your list.
Aspergillosis.
Yeah, totally.
What about cats?
Yeah, what about short-faced cats?
Short-faced cats. Cryptococcosis. Nasal cryptococcosis.
Yeah, practice about cats.
I think that's a good one to emphasize for us living in Sydney, because we do actually see quite a lot of crypto where we are, and there's kind of local pockets of it. But the textbooks never emphasize testing for crypto as much as we probably should, and it's a very minimally invasive test to do. What is the test?
LCAT blood test.
Right, exactly.
Is it on
You
the
could do
short-faced cats worse?
You can also do IMI, can't you? Because then you rule out, like, if it's negative, then it's more likely to be negative. And if it's a positive, then you do have to send the LCAT. Isn't that right?
What's an IMI?
Low test. I've been using it a lot more. It's so cheap compared to LCAT.
Yeah.
Oh, cool.
Which one, sorry?
Called an IMI, like all capitals IMMY. Probably stands for something that I don't remember. But do you remember?
Can someone write it down? I really don't understand.
Do you know what it stands for, Suja?
Just like that, no, but some lateral flow assay. I think immuno enzyme, I can remember the lateral flow assay, but I don't remember the it's like a Kate side thing. Like you can just don't remember the full form though.
Yeah, it's really easy to run. It's highly sensitive, so really good to rule out. But you do get false positives. So
Okay.
Because there was sorry to interrupt. There was a cryptococcosis case here, and they did the PCR assay. It was a cat, obviously, and the PCR has cryptococcus in it, and it was positive. And then they did the LCAT, and then it was positive, and then they started treating the cat with compounded fluconazole. So I just don't know if it's the same PCR or if it's another one for her.
It's not a PCR, this test.
Okay. IMI.
Yeah.
IMI is the brand name. I've just Googled it. IMI is the brand name of the company that manufactures it. And essentially it's like a snap test, but they've got a couple of different fungal organisms that they do for humans. The downside of a PCR with crypto is that it is a commensal. So you're going to get positives if you're testing for genetic material. The beauty of the LCAT is that it says that there's a reaction to that there's fungal organisms in the system, not just on the nose, on the tip of the nose. Does that make sense?
Yeah.
And it is, I think LCAT's still cheaper than a PCR, but obviously not as wide results if you're looking for like particularly viral disease in cats and stuff. Sorry, I jumped forward to diagnosis.
Yeah. Well, looking at diagnostics, so yeah, definitely cats, I guess, doing an IMI or an LCAT is a good part of the workup for a nasal. There's obviously different things you can do depending on what kind of machines and stuff you have at work, of course. But I get if you do have let's not worry too much about signalmen, but like what are the kind of tests we can do to try and investigate any kind of sneezing or nasal discharge or epistaxis? We think we need to do extra tests. If we like What am I trying to say?
If we want, maybe we want to do some imaging. But
Yeah.
I want to get blood pressure first.
Good.
Yeah.
Yeah.
That's really
Yeah.
important.
Yeah. Full bloods, but the book said that usually full bloods are quite unrewarding unless you do run clotting times, and then you can do an airway examination and the general anesthesia, or you can take cold radiographs and the GA, especially the open one view to get better visualization of the cruciform plate. But then it's better to go to a CT scan. And then from the CT scan, you do the rhinoscopy to hopefully sample the best areas for a biopsy. So there was like a good logic step, kind of like stepwise, that I thought it was quite interesting.
Yeah, that's perfect. I think first part there, coags, definitely, especially before antibiotics, super important.
Coags and platelets, like make a smear.
Smear, definitely. But as far as imaging goes, yeah, I mean, X-rays are really handy because they're just right there. And dental X-rays, most places have dental X-rays. If there's suspicion that there is a dental tooth-root abscess, those kind of things. That's what your suspicion is. But yeah, I guess X-rays do have limitations, as we all know, when we're looking at the nasal passages in the skull. It's such a complicated 3D structure.
Yeah.
When you're looking for really localized disease, it can be really hard to. Oh, perfect. Anna's got it. So you just get so much more detail for the more complicated things. But really, if you're looking for like really obvious turbinate destruction or bony lysis, then you might be able to find more information with the X-rays. I think is probably the main. But then I guess you won't know if it's cancerous or osteomyelitis of some kind, I guess.
Yeah. So you can see, so we quite often get owners coming in at a referral level and saying, well, we've already had X-rays done and they had a look in the nose and they didn't see anything. Or why do you need to do a CT as well as a rhinoscopy? Why can't you just do one or the other? And I showed them this picture and literally just Google nasal dog CT. And it's the slices through the dog's nose at various levels. And you can see the level of turbinate detail here. These are all little bones. These like gaps are so small. There is absolutely no way that you're going to be able to explore this maze and find a grass seed or a foreign body. That, like, we had a like 7 centimeter long piece of bamboo that was 1 millimeter wide, just sitting in one of these little holes, just went front to back in a kelpie's nose. And you could barely see it on these slices like this. It wasn't until we did the like transverse reconstructions that you could actually see it. But like there is absolutely no way to look at the nose unless you're mapping it with a CT, like to know that you're not going to miss anything. And even with CT, sometimes we miss stuff, but it's the most detailed structure. It's absolutely impossible to assess radiographically. So I guess radiographs help you like push people towards further diagnosis or say, yes, there's space occupying in the nose, but it's not going to help you differentiate nasal discharge from neoplasia, for example, because it will look exactly the same soft tissue density on one side or both sides.
Yeah, and I think it's also important as well, like CT, one of the limitations is it's hard to differentiate fluid from tissue sometimes, or so like nasal flushing can really affect that. So it's really important that we do it for any of those things.
Anna, can you miss a foreign body on CT? If you do a CT, can you absolutely rule out a foreign body, or you just make it less likely if you don't see one?
But so often they've got an inflammatory granuloma or a reaction around it, as well as all the snot. And as Josh said, if you've got that much snot, it looks exactly the same as soft tissue. It's still like radiographic density. So you can kind of do fancy stuff, but it can be really hard to find like grass material isn't bone density on a CT. And we often kind of go, okay, well, we need to look in this, there's like inflammation localized around this region on the CT. This is where we're going to flush and look with our rhinoscopy.
Yeah, we can definitely use that to target your biopsies, and biopsies can either be endoscopic during the rhinoscopy if you've got visualization, particularly in the back of the nose, or blind biopsies with going through rostrally. Super important to know that when you do blind biopsy, make sure you mark where the medial campus is and never go past it.
Otherwise, you end up picking up the brain.
Yeah, and you'll take the brain and then just send off your nasal biopsies, and they'll come back saying brain tissue. And
That's never happened.
if it's a pug, it might not be any different, but some dogs might change.
This is actually a good point that you raised, because every now and again you get a dog whose nasal planum is actually caudal to their medial campus. It's tricky.
I think that's generally the main stuff. I've got a little bit on here about how to manage epistaxis, but I don't think that's more emergency stuff. We'll get to that later. I got some cool pictures if anyone wants to see them. But
Yay, show us.
Yes.
I do. Hang on, maybe I need to open the pictures first. Sorry, I'm a bit of a noob when it comes to things. Cool. All right, I've got a video actually. Hopefully it works. This is one I think you and I saw, Anna, actually.
Sorry?
I think this is one that you and I might have seen.
Oh yeah, cool.
Good morning.
Morning.
Can you see that?
Oh.
Yeah.
This is a cat that presented presented with very acute onset sneezing. I can't remember its signalment, sorry. I think it was kind of middle age. And there's a little bit of nasal discharge, but I think it'd been going on for a few days. Anyway, this is what it looked like.
Oh dear.
So it kind of looks, I thought at first it looks kind of dyspneic.
Yeah, definitely.
And so you kind of start thinking, oh God, it's like a lower airway thing. It's got a pleural effusion or something, or it's got heart failure or whatever. But then you got these like really obvious sneezes.
Did it have a stutter?
I can't remember. And I don't know if Anna would remember, but
Often they've
It's,
got so much like that cat looks like it's obstructed.
Yeah.
So it's probably got no nasal noise. It's just now mouth breathing, and you're hearing that
yeah.
of cats
Anyway.
breathing the way they're not designed to breathe.
What we found, and I don't know, I might need to change what I'm sharing, but try and figure this out. Sorry. New share.
Josh, how old is this cat? I missed that, sorry.
I don't remember, sorry. I should
Okay,
look.
that's okay, that's okay. Yeah.
I think it was middle-aged. I don't think it
Middle-aged,
it could have been anything.
Whoa,
Wow.
We found a big grass blade. It was so cool.
it's bigger
Oh,
than the
no.
cat.
And I think it was, I'm pretty sure it was Yana, but I could be wrong. But I just remember like pulling it out, and it was one of those, oh my God moments.
Yes.
And just so satisfying because the cat was completely fine. And I think I vaguely remember we spoke to them about cancer and things like that. And we weren't sure, and there's a bit of a worry, and who knows. Anyway, from other things that we pulled out of a nose, this is another one that Jody pulled out.
So was that after doing a full workup, like
Yeah.
a CT scan and then rhinoscopy, and then you're like, oh, what's that?
To be honest, I can't remember. Sorry, I just thought it was really cool. But
Yeah, it's really
There
cool.
was something in CT that was very localized, and we went in. I do remember the rhinoscopy, but we went in and could see the grass or something
Right, yeah.
just right at the tip, and then we were able to pull it out. So
Are you talking at the from the nasopharynx side, like with retroflex scope?
did we see it on the nasopharynx side?
Yeah.
I think it was actually. I'm assuming it was going through the ventral meatus, but we could see it from the front, and we pulled it up
Wow, you got it. So you can scope a cat's nose.
just at the front. Like,
Okay.
you can't get much further in than that.
Not thoroughly. Not.
So
Wow.
I think we were super lucky.
He looked very looked quite like he was having dyspnea despite it only being unilateral. It's quite pronounced.
Right? Yeah.
In respiratory effort.
I guess
Yeah.
that's reverse sneezing for cats, is it? See that very often.
But
and
like I tend to freak out when I see a cat that is kind of like open mouth breathing.
Oh, yeah.
But yeah. Oh wow.
Oh,
Oh
wow.
this dog, I don't know, like I won't give you, I mean, this dog basically ran into the bushes and then came out sneezing. So the history was a bit easier, but yeah, we could see this on CT and pulled it out.
wow.
Huge. It was almost up to its medial canthus, so that could have touched the brain.
Yeah. Wow.
And then I think that's it. Probably over to you, Anna.
Over to me? Okay. I've got videos too. So definition wise, and my section is coughing. Definition wise, what is a cough?
A forced expiration of air from the thorax.
Yeah. Excellent. So the sort of key
Mouth.
coughing out of the mouth, exactly, as opposed to sneezing, which is mouth and nose, right? So cough is preceded by an inspiration, deep inspiration. So the lungs fill up to try and clear something out from the lower airways against a closed glottis. So the glottis closes, you generate a whole heap of positive pressure, and then you expel all that air that you've taken in. So if you've got you drink your water and it goes down the wrong way, is that a cough?
Is that a laryngeal spasm?
Yeah, well, it's different, isn't it? Because it's not preceded by that big intake of air to bring something right up. Afterwards, once it actually trickles down your trachea, then you're coughing for sure. But that first, like, that your body does to stop things going into your airway, that's called an expiration reflex. Expiration or expectoration reflex. I'm just going to read that. No, it's expiration reflex.
Expiration reflex.
Yeah, but it is expectorating, isn't it? I was like, I must have written this down wrong. Expiration reflex. So there's quite a big difference in terms of localizing where a cough sound comes from. There's quite a big difference between stuff that comes from up here that might be like a postnasal drip from a dog with caudal nasal cavity disease hitting their pharynx and larynx and the cough receptors there. That's going to present with a after drinking or after like a reverse sneeze or something like that. And we know, I think most of us have seen dogs with laryngeal paralysis have a drink of water and then go or a bit of a retch after they have their water. That's going to be the expiration reflex as opposed to a proper cough. And often that expiration reflex precedes a cough. So then you cough to try and clear it from the lower airways, but that first reflex is expiration. So that's going to help us to kind of characterize our coughs and localize our coughs a little bit. What other characteristics of a cough will help us to understand where the cough is coming from in the airways?
Productive hacking versus non-productive hacking cough.
Where does a productive cough come from?
From the bronchi.
The lower airways. It has to be bronchial or south of there. So it could be that the alveoli are really full of fluid and pus and phlegm or whatever, and that's worked its way up to the bronchi, and then you cough it out. But if there's stuff coming up, it's usually coming from the lower airways. Whereabouts in the airways, what's the lowest point where you'll get a cough? If you've got disease in trachea, will you get a cough?
Yes.
Yes. Bronchi?
Yes.
Yes, large bronchi, not the small bronchi.
Good. Bronchioles?
No.
No.
Alveoli?
No.
No, exactly. So in what situations would you get a cough in a dog with, let's say, pulmonary edema?
When it's dying, sorry.
Yeah.
When it's drowning, yeah.
Well, yeah. When the cardiogenic pulmonary edema, like you said, it's so bad that it has reached the bronchi or bronchial. So you have bronchi and then the bronchial and then the alveoli, right?
Yeah, so it's actually the bronchi. So it's got to move up to almost at the corona of the trachea before you'll get a cough.
Yeah.
they've got some help with that. It's not like the lungs are just like filling up progressively with fluid. We've got that mucociliary escalator, which in theory is bringing stuff up to the level of the cough receptors to facilitate bringing that stuff up. But edema, cardiac or non-cardiogenic edema, has been taken off the list of causes of coughs.
Yeah. Crazy.
Because
Yeah.
I just like.
I actually learned that by reading this chapter. I couldn't believe it.
Yeah, it's really amazing, and it's a huge shift in the way that we think about presentation for heart failure. I think there's a lot of people, I come to do an echo, and a lot of people still say, "Oh, but they're not coughing." It doesn't matter. It doesn't rule out pulmonary edema at all. So productive is a great way to classify productive or non-productive. What other describing words do you use for coughs?
Dry.
Good. Yeah. Dry, which probably is non-productive.
Hacking cough.
Hacking or honking. Where do you typically associate a honking cough with localization-wise? Trachea. Excellent. Yeah. So typically honking cough, what is the most common cause of honking cough in a dog?
Infectious bronchitis.
Tracheomalacia.
Good, actually. So probably different populations that you're seeing. In a young dog, tracheobronchitis for sure. In an older dog, degenerative changes in that trachea, so tracheomalacia. What other describing words?
Paroxysmal.
Great. Or single cough. What would, if you had a dog, I'm going to show you a video. I hope so. What do you think? How would we describe that one?
I couldn't hear a cough.
Yeah.
Sorry.
Me neither.
Turn my volume up. I don't know if I can turn my volume up. It might be beyond me. Oh, wait a minute. Sorry. Share sound. Got it. Okay, ready, set? Could you hear it?
Tracheal collapse, I suppose.
So I don't know what's causing it, but that was a very paroxysmal, dry, hacking cough, wasn't it?
Paroxysmal.
Yeah. So it could be tracheobronchitis, could be infectious disease, but obese old dog with a cushiony coat, I'm probably going to go dynamic airway disease or tracheal collapse in this dog as the leading differential. This dog, of course, also had a grade 5 heart murmur. So there's always things to rule out. Okay, so what other videos? How about I show you?
Can I ask, what is the actual definition of paroxysmal cough? Like I find that term to be a little bit confusing.
Just a coughing fit rather than a single cough. So if I'm like examining a dog and I tickle its trachea and it does 2 coughs, I'm going to say probably not paroxysmal. But if I tickle its trachea and then it does 5+ coughs, then it's definitely got some like ongoing triggering of the cough receptors, despite no
no, thank you.
active, okay. I don't know if you'll be able to. Oh, did I do it again? Hang on. The sound and there. Okay, so this is just the Edinger online version, and it's got some videos of coughs which are quite good. Can you see that?
Yep.
Great.
Oh dear.
So this is an older Labrador, obviously. I don't know what sex it is. What do you think about that cough? How would we describe that one?
I cough.
I was trying to decide if it was moist or dry. It did seem to lick its lips afterwards like it was moist.
Doesn't it? Yes. So I would say it's still a honking or hacking cough, but it's productive now.
Yeah.
So where would you be more likely to localize that to?
Lower
Lower airway.
Yeah. Yeah. So probably say that's quite a bronchial disease presentation, and there's so much overlap here. So I don't want you to go out and say, oh, it's definitely not tracheal because it's productive, because often we've got inflammation of the tracheobronchial tree. But we've definitely got a lot of coughing. We've got paroxysmal coughing, so coughing fits. And at the end, we've got a terminal retch, which probably means there's increased mucus production in those lower airways, or something that dog's trying to bring up. So phlegm, infection, or pretty much all I can think of. Blood. Why might it be trying to bring up blood? What would cause haemoptysis in an older dog like that?
cancer.
Yeah,
neoplasia.
leading cause of haemoptysis for sure. Let's do puppy, boxer puppy presenting with highly productive. So how would you describe that one?
Paroxysmal dry cough.
Yeah. Harsh or soft?
Soft.
Soft, wasn't it?
Yeah. Soft.
Yeah.
Hmm.
So those soft coughs I tend to associate with lower airway pathology. So I think we see a soft cough in dogs with pneumonia, as opposed to the harsh cough we see in dogs with tracheobronchitis. So again, a lot of overlap, and certain dogs will cough a lot more enthusiastically than other dogs just by nature. But it can sometimes help you localize. The dogs with aspiration pneumonia, often it's a really like huffing kind of cough, isn't it? When you've seen those dogs. So that just helps you to localize a little bit. What about cats? Do cats cough very often?
They do cough.
They don't
It's
cough.
just that owners can't tell because they think they're trying to bring up a hairball, which is not the case. Most times it's coughing.
Yes, good. That's so
Yeah.
often the history we get, and that's why those definitions are so important, isn't it? What's the leading cause of cats coughing?
Feline lower airway, inflammatory airway disease, like
Asthma. Yeah. So why this is probably a little bit too deep to go into for the presenting sound of coughing, but I was just going to ask, why is kind of asthma something that you can kind of say as a blanket statement for lower airway disease in cats as opposed to dogs? What makes a patient asthmatic rather than bronchitis?
Because of bronchoconstriction of the bronchi.
Yes. Active bronchospasm is what defines asthma as opposed to bronchitis. Now, if you've got chronic inflammation of your bronchi resulting in bronchoconstriction, is it asthma or chronic bronchitis?
That's chronic. It's bronchitis.
It's kind of both,
asthma.
isn't it? You meet both definitions. And I think there's a lot of we kind of try, it's nice to put an animal in a category, but particularly with cats and also with dogs with the kind of dynamic airway disease, we're often not dealing with disease in one segment of the airway or that fits in one category. So if you've got chronic asthma or chronic bronchial collapse, you've got your coughing against a closed airway. So when you're generating that positive pressure in the thorax to try and forcefully expel something from the lower airways, and either your bronchi or your trachea are closed against that, the positive pressure in your lower airways, which doesn't have a really firm wall, no cartilage, no kind of structure, is going to blow out, isn't it? And eventually, if it blows out often enough, it will lose its ability to regain its shape. And we'll get replacement of the lining of that airway with fibrous tissue instead of the mucociliary clearance mechanism. So if we've got chronic asthma or chronic airway collapse, dog or cat, and we're coughing against airways that are closed or collapsed, and we've got increased positive pressure in the lower airways, we get this condition called bronchiectasis, loss of mucociliary clearance, and that's chronic bronchitis or pneumonia, and certainly a predisposition for pneumonia if it's not always there. So there's a huge overlap between these kind of more upper airway conditions and lower airway manifestations. So the character of the cough and getting the owners familiar with how the cough sounds when it's upper airway versus if it's all of a sudden becomes a soft cough and my dog's flat now, then you probably have on your radar, I think we've got some pneumonia developing. Make sense? And same with cats. They kind of present with their asthma and then all of a sudden have a pyrexia and don't respond well to salbutamol, and there's an active infection going on associated with chronic bronchitis and the inability to clear that infection because they've lost their mucociliary clearance mechanism. How do we investigate a cough?
X-rays first.
Sorry?
Look at the breathing and then take X-rays like rats.
Yes, exactly. So what is going to be the difference if you've got alveolar or interstitial alveolar disease versus tracheal disease? What's your breathing going to look like?
So alveolar disease, because it's coming from the lower airway, it's an expiratory sort of breathing pattern, whereas inspiratory is usually extrathoracic.
Yeah.
But there's an overlap. Like usually you see an overlap. It's not so clear.
No. And I think the biggest thing is presence of cyanosis with lower airway disease versus upper airway disease. So dogs will usually have an increased respiratory rate if they've got barriers to gas exchange going on, as opposed to dogs who have got laryngeal or tracheal disease. Often they've actually got a slower respiratory rate because they're going, don't they?
So in the lower airway disease, don't you get an end expiratory push?
Yeah, lower airway disease.
Yes.
I reckon we see that with laryngeal collapse as well. They've often got abdominal effort at the end.
Okay.
I think anything obstructive that causes like a barrier to expulsion of air in the bronchi will cause that expiratory push. And then I think you're right. RADS is probably the next step, isn't it? Like we'd love to do bloods and stuff like that as well. We'll do that, of course. But what are RADS going to tell us?
The pattern, like distribution of, if there's stuff in there, distribution will tell us things.
Yeah.
And help us localize a bit better.
Yeah, good. How sensitive are radiographs for differentiating chronic bronchitis from tracheal collapse or detecting dynamic airway disease?
Not very sensitive.
Really good. No.
No.
Can I ask a specific question about this?
Yes.
Trying to do exactly this with radiographs recently, and I couldn't demonstrate. It had a characteristic honking cough, a very old dog. I was just certain it was tracheal collapse, and didn't capture it except when I squeezed the dog's trachea and made a cough. Captured a really narrow intrathoracic trachea, but the radiologist said it doesn't count because it was during a cough. It has to be during expiration. Would you agree with that? It wasn't a specialist radiologist. It was just a person who's interested in radiology, and I thought it counts. But
so this is a bit tricky because one of the ways that we diagnose airway collapse definitively is by bronchoscopy, and you trigger a cough by hitting the cough receptor at the carina of the trachea, and then you watch what happens. Most airways will collapse to a certain degree when you trigger a cough, and that's probably what they were getting at. It shouldn't be more than 50% of the luminal diameter though.
Okay. Right.
So that's probably the differentiator there. If you've got a flat trachea, it's you've got a diagnosis.
I've never done this, but like the books say that you should take expiratory and inspiratory views. Then your chances of actually capturing are more than just taking one view.
Definitely.
I've
If you
never
take
actually done
a
that.
radiograph, your odds are better. But I would say it doesn't really matter what phase of respiration they're at.
It's hard enough to get one phase. Like it's just so hard to get a proper inspiratory phase, to be honest.
Yeah. And I think conscious radiographs are better because they are there's more realistic inspiratory and expiratory pressures going on in the airways. But you can't, I mean, a lot of these dogs only have bronchial collapse. They don't have tracheal collapse. You can't really see that on a radiograph. It's really hard to diagnose. So bronchoscopy and fluoro are the best way to make a diagnosis of respiratory or airway collapse. And I do think pairing that with a CT is, again, similar to the nasal cavity. You can localize, oh, there's a dog biscuit in that bronchus, that's why that dog's coughing, or, you know, I've always hoped that that's the case. I've never seen it. But grass seeds, things that the dogs have aspirated, focal pneumonia, because often it's like it was an aspiration pneumonia and then it just hung around and it's in the right middle lung lobe, and you need to sample that lung lobe and the CT will tell you that. Whereas radiographs, you just don't get that same level of information. And most of these, like acute coughs, you know how to manage them. It's the chronic coughs where you kind of like, now it could be anything. We better wrap up, actually. I don't want to hold you up to start your days. Thank you so much, Josh. That was excellent. Next fortnight we are doing, I think that was excellent. I'm sure everybody agrees with me. Next fortnight we're doing coughing, sneeze, no we're not, that's today, tachypnea, dyspnea and syncope, which is exciting. Josh, do you want to take any of those, or have you got stuff that you've got to be?
Yeah, no, I can definitely. Can I text you?
Sorry?
But yeah, I can definitely. If you want to allocate one, sure. But otherwise, I can text you.
Oh, text me. Yeah, for sure.
I thought you said I can take two, and I was like, ooh la la.
I know, me too. I got all hopeful. All right, awesome.
So we're just going up the Ettinger, right? So it will be 28th and 29th chapter, or
28.
oh, 20.
30. 28 and 30.
Perfect.
Like Ettinger's order. I changed it.
Beautiful. Thank you so
All right.
much.
Thank you.
Thank you. Thanks, Josh. It was really good.
Yeah, thanks, guys.
Bye.
Yeah.
Bye.
Bye.